moving on to the second scenario. So there is a 40-week-old boy
1
baby.
second, Jyoti, is Dr. Narasimha joining or what's the
So
back?
there is one participant called VL Narasimha Rao. I don't know whether he's the same person.
Yes, same person.
Same person? Okay, yeah, then he has joined.
Okay, so Netra will finish in 10 minutes for this case.
Sure,
so
sir,
that
sure.
Dr. Narasimha can present as well. Okay.
Sure, sir. So we have a 40-week. Okay. So there is a 40-week boy baby delivered to a tiny gravida mother by emergency LSCS in view of non-progression of labor. Baby cried at birth and DCC was done, but developed respiratory distress at 3 minutes of birth with a respiratory rate of 70 per minute, mild retractions, cyanosis, grunting which was audible without stethoscope, and with good bilateral air entry. Calculate the Downe score of this baby.
So I think Dr. Dharini can answer this. Dr. Dharini, can you please unmute yourself and speak?
Okay. So I'm audible?
Yeah, you're audible.
Yes.
Go ahead.
So Downe respiratory rate is 70 to 1. Child is having cyanosis in second 1, and retractions are there again 1, and grunting is there without sensitivity, and bilateral air entry is good to 0. So, and since
Okay. Dr. Netra, you can go to the
Yes, sir. Yes, sir. So the scores for respiratory, cyanosis, retractions, and grunting are 1, and audible grunting without stethoscope is 2, and air entry was cleared, so 0. So the total score comes up to 5 by 10. So the baby is in respiratory distress as per the classification and interpretation. So moving on to the next question. How
Just
do you
a big
manage?
point about the use of scores for respiratory distress. Obviously, some of you are using it routinely. Some of you may not be applying it. But if you have a big team and you have a communication over phone, for example, to discuss, this makes you having an objective approach. In the previous case, you mentioned Silverman scoring of 7, and that's because this was a premature baby with more retraction. So if you have a premature baby with the RDS setting, the Silverman score is better. And Downe score applies to both term and premature babies. So Dr.
Yes.
Dharini, it was not very clear. Your audio was not very clear, but it's okay. So if you are not using it, if you are a one-man army and you are just assessing and making the decisions yourself, educate your nurses on this, so that if you get a call from them and they describe this and they give you a score, it becomes easier for you to assess. If you are a bigger team and you are speaking to your senior over the phone, for example, again, document the score and discuss the score so it's more objective. And it's not definitive that if you have a certain score, you need a certain action. You need to overall look at the overall picture. You need to look at the FiO2. You need to look at the baby's condition, the chest X-ray. So it's a rough guide. Some of you may say more than 7 needs intubation or 4 to 6 CPAP is enough and so on, but it depends on the baby. So don't be dogmatic about that part of it. So let's move on. Continue.
Okay, sir. So the baby is in respiratory distress. The second part of the question, how do you manage this case in the delivery room? A baby with respiratory distress who is term baby, how do you manage this case?
So Dr. Ranganath has already mentioned adequate respiratory support, delivery room CPAP. And if you are using PPV, you should use PEEP. So that means don't use the bag, use the TP's device. Okay.
Okay. Yes, sir. So start with the CPAP, TPs with FiO2 of 21% and PEEP of 5 with a good seal, and adjust the FiO2 to meet the target saturation as per the Dawson's charts. So moving on to the third question of the scenario. So now you have started CPAP at 3 minutes of life with a PEEP of 5 and 21% FiO2. Cyanosis is improving clinically, but the pulse oximetry shows saturation record of 65% at 5 minutes of life. What is the next step you will take in the respiratory management of this case?
Dr. Sai Pratap, you had a question on the use of high flow. Do you want to tell your opinion and then answer this question as well? And then we will discuss. Please unmute yourself.
Sir, yes, sir. Actually, that is term baby. Usual causes are TTNB in this type of child. So but distress is more moderate respiratory distress. But in terms of TTNB with term baby, it's consideration of high flow in HFNC.
So here the question is in the labor room. Obviously, in the labor room,
Yes,
you're mostly using the TP's device where you'd give CPAP. But once you come to the NICU, so we have 2 categories of babies where you expect the disease to be evolving where the distress could increase and you want to titrate the PEEP. In those cases, it's better to go for CPAP. In high flow, you have a little limitation. You can go up to 8 liters flow in the term babies, but still the PEEP delivered is not measured, and the ability to manage them with the higher pressure is not that controlled. So if you think the disease is evolving or worsening, if your oxygen requirement is high or the baby is a significantly small baby, go for CPAP or NIPPV. But if the baby is relatively stable TTN and you expect the baby will stabilize within 1 to 2 days and you don't expect immediately to worsen, you can consider high flow. So the answer is you can consider, but where the disease is increasing in severity, I wouldn't consider high flow. So when you're shifting to the NICU, you can assess your prediction. Most of the time, you can look at the distress, the oxygen requirement, and make a decision. Of course, most of the units now are using the same circuit for both options. If you have the bubble CPAP, you can use the same circuit, slightly modified to use it for high flow as well. So you don't need to waste a circuit for that. It's just switching them. You can use mass CPAP with the Neoco, for example, when you're switching them. What is the recommended interface for CPAP administration during transport? So again, it depends on if you have a transport ventilator and you can use a RAM cannula connected to it. If you are moving in the open care system, for example, you can have the gas open and the TP's device can continue to provide your CPAP. Depending on the distance, how you are moving, be careful not to tread on your colleague's toe if they are holding the mask, because it can be really painful to have a warmer or an incubator climbing on you. It's easier to move holding on a warmer than an incubator because the back position. So remember that ergonomics and everything is important for the supporting team as well. So the best solution, if you have a transport incubator, RAM cannula can be used to shift the baby, or even a CPAP setup can be set before you move. But if you are moving in a warmer, it's acceptable with the TP CPAP as well. So the pulse oximeter part, I mean, Dr. Sai Pratap, do you want to comment on that?
Yes, sir. Even at 5 minutes, saturation is 65% means, which is target lower than targeted range. Usually target is 80 to 85 range. And at the same time, cyanosis is improving, but saturation is not achieved. So first thing Dr. Rangnath sir mentioned clearly, it is good also pulse oximetry connected accurately or not. Second thing, if connected accurately, then go with increase FiO2, because we are connected in the 21%, which is lowest level, but we can go up to 30% minimum FiO2. Still, it is not improving, then we have considered up to PEEP increasing also, because it is PEEP also 5 mmHg and the distress is moderate respiratory distress.
Okay. Dr. Deepika, do you want to differentiate the pre and post ductal saturation? What is the difference between the two? And in newborns, what saturation are you using? Please unmute yourself, Dr. Deepika.
Sorry, sir, I didn't get your question.
No, can you explain the difference between pre and post ductal saturation? And in the labor room, which one are you looking for?
Sir, in the labor room, we'll be definitely looking for the postductal saturation, and we have to check for. Sorry.
Which hand are you looking at?
For preductal saturation, I'll be choosing the right upper arm, and the postductal saturation, I'll be choosing any of the lower arms, lower limbs.
In the labor room, what did you say?
In the labor room, we are going to look for the preductal saturation, sir.
Preductal, yeah. Initially, you said postductal, but that was a slip of the tongue. Yeah. Go ahead.
Sorry.
You are looking for the preductal. Yeah, that's because you are looking at the optimal saturation to the brain, right?
Yes, okay. Yes.
And we know the PDA is open and the baby is still having pulmonary hypertension evolving. So it's in the adapting phase. So you don't want to look at the postductal to titrate your oxygen. You may overdo it. So Dr. Narasimha's presentation will discuss a lot on oxygenation. So we will not spend too much time on this part. Can you move on, Dr. Netra?
Yes, sir. Yes. So it was answered correctly. So the saturation target at 5 minutes of age was 80 to 85%. So we can increase the FiO2 to meet this saturation and then consider increasing the peaks. So next question, interpret the X-ray of this baby and give the diagnosis, the same baby.
Okay, Dr. Ishita didn't speak so far. Dr. Ishita, do you want to try? Please unmute yourself.
Yes, sir. This X-ray is well centralized. Exposure looks good, but there are heterogeneous opacities all over the lungs, especially on the. I mean, there is no marking here, but I assume on the right side there are more of heterogeneous opacities. So to interpret the X-ray, I would like to have a history, sir. If it is the same baby, It could be more of TTNB. There is sunburst appearance also, so it is more suggestive of TTNB.
Yes. So, I mean, this is the same baby. And yeah, proceed,
Yes.
Dr. Netra.